Good morning. Uh, Today we are going to discuss about the disorders of anxiety, fear, and panic. In last class, we have discussed about the psychological disorders in general, and we have discussed in brief about the each and every disorders. Today we are going to discuss in detail about the fear, that is phobia, and panic disorders. So today we'll cover the introduction, difference among fear, panic, and anxiety, clinical features of phobia, why do phobia develop, treatment of phobias, then clinical features of social phobia, that is called social anxiety disorder also, causal factors of social phobia, treatment for social phobia, clinical aspects of panic disorders, causal factors for panic disorders, and treatment of panic disorders. So it is important to look at certain situations when the individual remain anxious irrespective of the situation and is unable to cope with it. When this happens, the person is said to be suffering from anxiety disorders. So different types of anxiety disorders according to DSM-5, generalized anxiety disorders, which we are going to discuss in our next class, specific phobia, social phobia, agoraphobia, and panic disorders. So what are the components of anxiety? There are three components: cognitive, physiological, and behavioral. Under cognitive, like there will be some certain thoughts, I am afraid. Physiological, increased heart rate, fast and heavy breathing, shivering, traveling, and behavioral, strong urge to escape from the situation. So what are the components of fear? Let us see, like again, physiological, cognitive, and behavior. Chronic tension and over-arousal, low pulse rate, dry mouth, butterfly sensation in the stomach. Then under cognitive, negative mood, worry about possible future danger threat, self-preoccupation, inability to predict and to control the occurrence of future danger or threat. Under behavioral, avoidance of anticipated dangerous or threatening situation, but there is no immediate urgency to escape as seen in fear. So let us see the difference among fear, panic, and anxiety. Cognitive, physiological, and behavioral components are involved in all. Phobia is experienced in the presence of real danger or threat. Anxiety is experienced only in anticipation of danger, threat, when such a danger threat is not present or cannot be specified. Panic has all the above three components. Additionally, panic attack is characterized by subjective feeling of impending doom, fear of dying, going crazy, and losing control. Let us discuss the phobia. So, what is phobia? Phobia is a persistent and disproportionate fear of an object or situation that presents little or no actual danger to a person. So, according to DSM-5, three categories of phobia: specific phobia, social phobia, agoraphobia. Specific phobia. So, what are the criteria for a specific phobia according to DSM-5? So, the first one is marked and persistent fear that is excessive or unreasonable, cued by the presence or anticipation of a specific object or situation. For example, flying, heights, animal, receiving an injection, seeing blood, etc. Exposure to the phobic situation almost invariably provokes an immediate anxiety response, which may take the form of a situationally bound or situationally predisposed panic attacks. When the person recognizes that the fear is excessive or unreasonable, so it means the person is aware, well aware that his fear or her fear is excessive or unreasonable. Reasonable. The phobic situation is avoided or else is endured with intense anxiety or distress. The avoidance, anxious anticipation, or distress in the feared situation interferes significantly with the person's normal routine, occupational. For example, for students, it's academic and academic functioning, or social activities or relationship, or there is a marked distress about having the phobia. So, and then we let us see the specific Phobia, so specific phobia is diagnosed when a person shows a strong and persistent fear which is triggered by a specific object or situation. Individual shows immediate fear response that resembles a panic attack except for the presence of a clear external trigger. The person is fearful and avoids even the mere representations, picture model of the phobic stimulus. It's not necessary that only in real situations this may happen, even though the picture or imagination may cause the specific phobia. And people who suffer from a specific phobia are likely to suffer from other anxiety disorders also. Let us see the prevalence of specific phobia, means how much commonly seen it is in the society. So lifetime prevalence for a specific phobia is around 12%, which implies that these phobias are quite common. So if we consider our prevalence in our population, it will be more than 13 or 14 crores people are suffering from phobias. In India, prevalence rate has been reported to be 4.2, which is significantly lower as compared to other countries. But it depends upon the differences in the methodology and the sample which were taken for the study. Despite being very common, people with specific phobias are less likely to seek treatment than people with other anxiety disorders. The most common specific phobias are fear of spiders, snakes, heights, cockroaches, etc. Phobias are also depend on culture. So it means the one type of phobia may be seen in a particular culture may not be seen in same type of phobia in another culture. The age of onset for specific phobias varies depending upon the type of the phobia. Animal phobia, storm phobia, blood injection injury phobias typically begin in early childhood, whereas the average age of onset for height phobias is in teens. And specific phobias of enclosed places, claustrophobia or driving phobia often begin in adolescent and early adulthood. There is a gender differences also. Some specific phobias, for example, spider, cockroach, lizard, storms are much more common among women than men. Others like blood phobias are more equally found in men and women. So let us see the general characteristics of the phobias. So people with phobias usually know that their fears are somewhat irrational, but they cannot help themselves, as we have already discussed. If they attempt to approach the phobic situation to overcome with fear or anxiety, which may vary from mild feeling of apprehension to distress to a full-fledged activation of the fight or flight response, very similar to panic attack. Phobic behavior tends to be reinforced by the reduction in anxiety that occurs each time a feared situation is avoided. And the phobias may sometimes be maintained by secondary gains such as increased attention, sympathy, and some control over the behavior of others. These benefits are usually not in awareness of the sufferers. So, why do people develop phobias? Some others may not develop, some may develop. So, what is the reasons behind that? So, we can divide all these reasons under three categories: biological, psychological, and evolutionary. Under biological, genetic factors and neurotransmitters play an important role, we all know. Under psychological perspectives, psychoanalytic viewpoint, behavioral perspective, cognitive perspective. Under behavioral perspective, learned behavior and observational learning also play a very important role. Let us see these things in little detail. So, genetic factors. The speed and strength of conditioning of fear is determined by genetic and temperamental as well as personality variables. People who are carriers of one of the two variant on the serotonin transporter uh, gene, which is linked to high neuroticism, are more likely to be conditioned to fear stimuli. Behaviorally inhibited, shy or timid toddlers showed a higher risk for the development of multiple specific phobias at 7-8 years of age than were uninhibited toddlers. Elevated risk of specific phobias in first-degree relatives of those who had been diagnosed with specific phobias. So, twin study on females and males found a higher concordance rate for animal phobias in monozygotic than dizygotic twins. So, genetic studies well established that there are some predispositions in the person for developing phobias. Coming to psychoanalytic perspective on the psychological factors, according to Freud, phobias represent a defense against anxiety that stems from repressed impulses of the id. And we'll discuss in some other classes about id, ego, and superego. As it is too dangerous to know the repressed id impulses, the anxiety is displaced, that is defense mechanism called displacement, onto an external object or situation that has some symbolic relationship to the feared object. Freud explained the development of phobia with the case study of little Hans, a 5-year-old boy with a phobia of horses. Freud suggested that Hans' phobia was developed as a result of anxiety due to Oedipus complex. Hans unconsciously hated his father and wanted to kill him and possess his mother. This led to a fear in Hans that his father would kill or castrate him for having such a negative feelings. So, but there are lots of criticisms of psychoanalysis. So, like one is that this explanation was criticized as being for too speculative by many researchers, and an alternative explanation of Hans phobias in terms of learning theory was provided by behavioral theorists. So, coming to behavioral perspective of developing phobia. So, generally, behaviorists they highlight or they emphasize learned behavior for developing any type of psychopathology. So, Ulpe and Rachman suggested that Hans' horse phobia originated from an instance of traumatic classical conditioning. He had witnessed an accident in which a horse was badly hurt. It upset him so much that he started to avoid leaving the house so as not to encounter the horses in the street. Studies also supported the viewpoint of the classical conditioning. The individual learns to fear a previously neutral stimulus which is paired with a noxious object or event. Once a phobia is acquired, it gets generalized to similar objects or events. We all know that in classical conditioning, Pavlov talked about the generalization, and conditioning and generalization. Coming to Bandura's observational learning, phobias can be acquired by merely observing another person who acts fearfully to a given object or situation. So this happens when in the family already father or mother, if they are having phobia, so children may learn this behavior very easily. For example, lab-reared monkeys who were not initially afraid of snakes rapidly developed phobias of snakes after observing their wild-reared counterparts behaving fearfully with snakes. This implies that phobias can be developed through mass media also. This involves informational learning, where an individual learns to fear a particular object or situation by hearing or reading that the situation is dangerous. So we all know that some of the information we just gather from the social media and we get fearful. We may develop phobia also. Let us see the cognitive perspective. So cognitive perspective talks about attention, memory, cognitive biases, a role of these things in maintaining or developing the phobia that have been acquired. Generally, people with specific phobias tend to pay more attention to threatening information that relates to their fear. For example, individuals with spider phobia are often the first people to spot a spider if there is one in the room. Others may not see, the person who is having phobia may see it very quickly. People with phobias also tend to have distortions in their memories for encounters with the objects and situations they fear. So people with specific phobias tend to hold beliefs and to interpret situations in such a way as to maintain or increase their anxiety. For example, people with a fear of height may assume that they are more likely to fall. People who fear enclosed places, such as elevator, may believe that they will run out of air or that they will be unable to escape in case of any accident happens. Avoidance of feared situations prevents people with specific phobias from learning that the situations they fear are not as dangerous as they feel. In addition, relying on safety behaviors, we'll discuss in detail about the in next few slides about safety behaviors. For example, driving extra slowly to avoid an accident, always wearing shoes to prevent insects from touching one's feet, can also help to maintain a person's fear. Let us see the treatment of phobia, how psychologists can manage phobia. So there are exposure therapies. The client is exposed to the feared object, animal, or place in a controlled environment. And there are three types of exposure: systematic desensitization, flooding, virtual reality. And another type of intervention is called modeling, based on Bandura's vicarious learning theory. The client either observes another person, sometimes the therapist, in real life or in a movie, acting fearlessly in a situation that causes phobia in the client. This helps the client to understand that the phobic situation or the stimulus is harmless or not as dangerous as they think. So let us see what we do in systematic desensitization. It is based on the premise that one cannot be anxious and relaxed at the same time. So either you will be anxious or you are relaxed. And both things cannot happen at the same time. It is conducted in several steps. Firstly, with the help of client, a hierarchy of the fears eliciting situation is formed or listed, beginning from the least fear producing to the most fear producing situations. For example, dog barking in the next lane to the dog barking just in front of the client. So there is a difference. Secondly, the client is taught relaxation exercises such as progressive muscular relaxation or deep breathing. Then the person is asked or client is asked to relax and imagine the fear producing situation in the ascending order to the of the hierarchy, beginning from the least fear producing situation to going to the most fearing situation. Gradually, the client learns to relax in the most fear producing situations, thereby they overcome the phobias. So it is done with a great caution. The way we are discussing, it's not so simple in practice. It requires lots of skills before doing this therapy with the patient. Flooding is another type of exposure therapy. The client is exposed to the most fearful situation and is taught that he can go through the fear-producing situation without being harmed, contrary to his expectation of getting hurt. The earlier therapist used the real situations or imagination if the situation was hazardous, whereas now the therapist uses virtual reality. In this type of therapy, the therapist, with the help of computers and other equipments, simulate the fear-producing situation, for example, heights, air travel, and the client is exposed to the simulation exercises. Through all these techniques, the client realizes the irrationality of his or her fear, and thus the fear gets extinct. So, as I told you, the flooding, it causes lots of anxiety in the patient. So it should be done very carefully with proper training and adequate skills. Coming to social phobia, it is also called social anxiety disorders. Social phobia is a fear of social situation. Social phobia is a persistent, irrational fear generally linked to the presence of other people. A person is afraid of acting in a humiliating or embarrassing way when he is exposed to the scrutiny of others. It may be specific to a situation such as fear of public speaking or generalized as in fear of many different social interactions. DSM-5 describes social anxiety disorder as disabling fears of one or more specific social situations where the person fears of being exposed to the scrutiny and potential negative evaluation of others, or that he may act in an embarrassing or humiliating manner. For example, stage phobia or talking in a group. The person tries to avoid such social situations, or when avoidance is not possible, endures them with great distress. There are two subtypes of social anxiety disorder according to DSM-5. One is specific to performance situation, for example, public speaking, and the other is general or in non-performance situations, for example, eating in public. Criteria for social anxiety disorders. A marked, as we have discussed, a marked or persistent worry of one or more social or performance situations in which the person is exposed to unfamiliar people or to possible scrutiny by others. The individual fears that he or she will act in a way or show anxiety symptoms that will be humiliating or embarrassing. Exposure to the feared social situation almost invariably provokes anxiety, which may take the form of situationally bound or situationally predisposed panic attack. The person recognizes that the fear is excessive or unreasonable. The feared social or performance situations are avoided or else are endured with intense anxiety or distress. So you have to avoid, otherwise you have to face intense anxiety. The avoidance, anxious participation, anticipation, or distress in the feared social or performance situation interferes significantly with the person's normal routine, occupational, that is academic functioning, or social activities or relationship, or there is a marked distress about having the phobia. The fear or avoidance is not due to the direct physiological effect of substance or a general medical condition, and is not better accounted for by any mental disorders, for example, pervasive developmental disorders, epilepsy, uh, autism, etc. So I'm repeating few things again and again, like avoidance, anxious anticipation, distress in fear, social and performance situation, interfere significantly with the person's normal. So these are the basically core things about the social phobia. Comorbidity means presence of other illnesses when the person is having or social anxiety disorders. So it has been seen that people who suffer from social anxiety disorders are also likely to suffer from one or more anxiety disorders and depressive disorders. Generalized social anxiety disorders has been found to be comorbid with depression and alcohol abuse. Specific social anxiety disorder is comorbid with generalized anxiety disorders, specific phobias, panic disorders, avoidant personality disorders, mood disorders, and alcohol abuse or smoking. Let us see the prevalence, age of onset, gender differences, and cultural factors in social anxiety disorders or social phobia. Its lifetime prevalence is 12%, as we have discussed also earlier, in a given population. In India, it's at 12.8%, generally seen in adolescent and young youth. It is a persistent disorder with spontaneous recovery shown only by 37% of the sufferer over 12 years. So, some of us around 20 and 37% will recover by their own without getting any treatment or any help. Social anxiety disorder usually begins during early and middle adolescence or early adulthood. Social anxiety disorder is more common among women than men, as 60% of the women have been reported to suffer from the disorder. Social anxiety disorder is also affected by cultural factors. So not only social anxiety, almost all type of psychopathology, they are affected by cultural religious factors. Let us see the causes of social anxiety disorders. So biological perspective. So let us see the role of genetics and temperament. So results from a very large study of female twins suggested a variance of 30% due to genetic components in development of social anxiety disorder. Family studies also show that the first degree relatives of probants were more than two to three times as likely to also share a diagnosis. Furthermore, infants easily distressed by unfamiliar stimuli are at an increased risk for becoming fearful during childhood and by adolescence, show increased risk of developing social phobia. How behaviorists explain this social phobia? So, social anxiety disorder in many cases is a result of direct or vicarious classical conditioning. People with generalized social anxiety disorder reported direct traumatic conditioning experiences. They may be especially likely to have grown up with the parents who were socially isolated or who devalued sociability, thus providing ample opportunity for vicarious learning. Cognitive perspective, the socially anxious people are more concerned about evaluation than people who are not anxious and are more aware of the image they present to others. They tend to view themselves negatively even when they have actually performed well in social interactions. So those who are having social anxiety disorders, they believe that they are not so good. It is just their perception. Others may not have same thing, may not believe, may not think about him or her the same way. It was reported that people with social phobia showed more negative articulated thought in a stressful situation in comparison to people without social phobia. Persistent and irrational fear actually occurs because fear is elicited through early automatic processes that were not available to conscious awareness. It means that the person who develops fear or phobia is basically not aware about the negative thoughts or automatic thoughts which come into his mind. After this initial processing, the stimulus is avoided, so it is not processed fully enough to allow the fear to extinguish. Another model explains social phobia on the basis of social skills deficit. So, inappropriate behavior or a lack of social skills is the cause of social anxiety. The individual has not learned how to behave so that he feels comfortable with others. So, if you haven't have any skills which make you comfortable in presence of others, you may feel very uncomfortable. The person repeatedly commits silly mistakes. Person is awkward and socially inept, often criticized by social companions. Sometimes the person develops social phobia due to criticisms done by the co-workers, friends, family members. Support for this model comes from findings that socially anxious people are indeed rated as being low in social skills. So, in certain research findings, it has been seen that they are lacking social skills and they get feedback about their lack of social skills and they develop social phobia. Perception of uncontrollability and unpredictability. So, submissive and unassertive behavior, which is a characteristic feature of people with social phobia, is a result of uncontrollability and unpredictability in life situations. So, the person may always have idea that he cannot control the situation, he cannot manage the situation, so the person become anxious. People with social phobia have a diminished sense of personal control over events in their lives. Evolutionary perspective talks about social phobias may have developed as a byproduct of dominance hierarchies. Aggressive encounters between members of a social groups establish dominance hierarchies where a defeated individual usually displays fear and submissive behavior but rarely escapes from the situation. Thus, people with social phobias are more likely to endure being in the feared situation than to run away. Perhaps social phobias develop mostly in the adolescence and early adulthood when dominance conflicts are most prominent. Let us talk about the treatment for social anxiety disorder or social phobia. Cognitive behavior therapy uh, basically talks about cognitive restructuring along with the behavioral techniques has been proved to be the more effective as compared to the only using behavior therapy. The distorted cognitions of client that lead to social phobia, such as nobody likes me, people do not find me attractive, are identified, and the therapist helps the client to restructure such negative cognitions through reanalysis. During the reanalysis, the client is educated about the origin of cognitive distortions, the automatic negative thoughts, and how these affect and client's social behavior, and restructuring such thoughts by cognitive techniques. For example, questioning the validity of such negative thoughts, taking negative thoughts as hypotheses, and logically testing these hypotheses. The clients are also encouraged to do exercise where they are taught to shift their focus from self to others and the situations. Videotaping of their social interactions has also been successfully used as a feedback mechanisms. So in cognitive behavior therapy, if we are using, so what happens? Suppose the student think that he is not very good student, he is not liked by his teacher, and one day in the corridor while he was going to the into the class, he saw his teacher. He wished him, but teacher didn't reply. So he will get the thought that, oh, because I am not good, the teacher does not like me. That's why teacher had not replied my wish. And I said good morning, but teacher didn't. But so we help the psychologist role is to help the student to understand the find out the other alternatives. What could be the other possibility? That is one possibility that teacher doesn't like you. The other possibility could be your voice was so low so the teacher couldn't hear, or the teacher was so preoccupied that he has not noticed or he could not reply. He noticed but he could not. So there are so many other alternatives. So why only take just one? Why only accept just the negative one? So let us see all the alternatives, and there is a possibility of all. So why there is no need to select anyone. Coming to panic disorders. Uh, like DSM-5 defines a panic attack. There is a difference between panic attack and panic disorder. Panic attack is a single episode, whereas when such episodes occur again and again, it is called panic disorder. So DSM-5 defines a panic attack as a discrete period of intense fear or discomfort in which at least four form four from a list of 13 standard symptoms develop abruptly and reach a peak within 10 minutes. So this 10 minutes is very important for panic disorder, panic attack. Although the symptoms must peak within 10 minutes, the attacks often peak within a few seconds, and the symptoms gradually subside over a period lasting from a few minutes to about a half an hour. Panic attacks are experienced across all the anxiety disorders triggered by a feared situation, objects, thought, worry, etc. Many people without an anxiety disorders may experience panic attacks from time to time. For example, when giving a formal presentation or taking an exam or upon encountering some other stressful situation. Unlike most panic attacks, which are typically triggered by stress, worries, or fear situations, the panic attacks that occur in panic disorder often occur out of the blue without any obvious trigger or cause. Panic attack versus anxiety. So let us see the symptoms develop abruptly in panic attack, whereas in anxiety does not have an abrupt onset. So slowly, gradually, symptoms develop and they remain for longer period of time. Usually, in panic attacks usually reach peak intensity within 10 minutes, subside in 20 to 30 minutes. Whereas in anxiety, symptoms are not as intense as in panic and may last for longer period of time. Panic attacks rarely last more than an hour, and anxiety disorder is basically anxiety is long lasting. See, there are two types of panic attack. One is due to cue or situationally predisposed panic attack, another one is uncued or generalized panic attacks. So, in acute or situationally predisposed panic attacks, panic attacks linked to specific situations such as driving a car, they are strongly associated with the situational triggers. So, there must be a situational triggers. Whereas acute panic attacks may occur in unexpected or benign states or in the absence of any provocation. For example, in sleep, which is known as nocturnal panic. Panic disorders and agoraphobia. In case of some people, panic disorder may lead to agoraphobia. In DSM-5, panic disorder is diagnosed as with or without agoraphobia. The term agoraphobia comes from a Greek word agora, which means market, hence it means a fear of marketplace. Though it implies a fear of open space, however, people having agoraphobia are much more fearful of enclosed spaces such as tunnels, small rooms, elevators, etc. Some people with panic disorders develop a concern that they will not be able to make an exit from a crowded place if they have a panic attack. Hence, hence they avoid going to places where they believe that their escape would be difficult in an emergency, that is panic attack, and it would cause embarrassment to them. At first, people avoid those situations where they developed agoraphobia, but soon it gets generalized and they begin to avoid not only places outside home such as market, elevators, public transport, but sometimes places within home also, for example terrace, and which they believe they would difficult to escape from there if something happens. Most but not all people with panic disorder develop at least some degree of agoraphobia. Usually, people with agoraphobia are able to leave the house if someone they know accompanies them, whom they believe will be able to help them in making a safe exit in case of a panic attack. So see the comorbidity. Many people, around 83% approximately, suffering from panic disorders with or without agoraphobia, also have some other psychological disorders such as generalized anxiety disorder, specific phobia, social phobias, depression, substance use disorders such as smoking and alcohol consumption, and avoidant personality disorder. The lifetime prevalence for panic disorder with or without agoraphobia has been reported uh, to, to be 4.7%, but panic disorder without agoraphobia is more prevalent. Prevalence varies across culture, and attacks involves intense fear, disorientation, and concern about drowning. Panic attack or panic disorder with and without agoraphobia is more prevalent in women than in men, with a prevalence of 5% and 2% respectively. About 80 to 90% of panic patients with agoraphobia are reported to be women. Men with agoraphobia often indulge in self-medication with nicotine and alcohol to endure panic attacks and often do not develop avoidance behavior, though its symptoms may increase or decrease at times. However, it has a chronic course. Recovery may take a long time, 12 years, as reported in a longitudinal study, with recurrence in 58% of the patients. The age of onset has been found to be 23 to 34 years on an average. For women, it usually starts in 30s or 40s. Its onset is associated with stressful life experiences. So, if there are stressors, there is a possibility that there might be some other comorbid disorder will be there. Let us see the causes of panic disorders. As we have seen in phobia, the biological perspectives, we have to see the genetic variables, brain activity, dysfunctional biochemistry, and then psychological perspective, behavioral factors, cognitive factors, anxiety, sensitivity, and perceived control, safety behavior, and the persistence of panic, and cognitive biases and maintenance of panic. So research found that an overactive amygdala is implicated in panic disorders. Amygdala is part of the brain. So amygdala, consisting of a group of nuclei, is located in front of the hippocampus in the limbic system, and its role in emotion of fear has been established through empirical research. Amygdala is said to be at the center of the fear network and is connected to the lower brain areas as well as higher cortical areas like prefrontal cortex. Hence, panic attacks may occur either due to stimulation of lower or higher areas of brain. The noradrenergic and serotonergic systems are known to be involved in panic attacks. The noradrenergic systems get activated due to stress and in turn leads to cardiovascular symptoms which provoke panic attack like heart beating, increased heart beating. On the other hand, serotonergic systems activation decreases the noradrenergic activity. This has been supported by the medication results, like when we give the anti-panic drugs. So, as the drugs used for treatment of panic disorder not only decreases the noradrenergic activity, but is also increases the serotonergic activity. Another neurotransmitter that is called GABA, which has an inhibitory effect on anxiety, has also been found to be abnormally low in people with panic disorder. Thus, such people suffer from anxiety in anticipation of suffering from another panic attack. So, anticipation of having another panic attack may also lead to panic attack. Let us see the behavioral perspective. It has been suggested that a comprehensive learning theory can account for the development of panic disorder. Through classical conditioning, interoceptive cues like heart palpitation, stomach ache, and exteroceptive cues such as a place or presence of specific people that were present during the initial panic attack gets associated with it and later on act as trigger for anxiety about future panic attack. In simple words, people end up developing a panic about a panic attack. This also explains the agoraphobic avoidance of the places like markets or shopping malls, as this serves as a exteroceptive cues for an oncoming panic attack. So, inhibitory learning, which is required for extinction in classical conditioning, you might have studied extinction also when the paired stimulus, when it is depaired, so which was eliciting the conditioned response. So, after some time of the trial, the extinction will be there. So inhibitory learning, which is required for extension of a conditioned response, has been suggested to be impaired in panic disorder. Thus, people with panic disorder are unable to learn to discriminate the conditioned stimulus as a safety cue. However, panic attacks sometimes seem to be uncued, that is, no trigger, internal or external, seem to be present before the panic attack. It means without any cue also there will be a possibility of having panic attack. This is because panic attack is in some cases result from the internal cues that are unconsciously experienced by the individual, as Freud has explained in the psychoanalysis. This can be understood with an example of a person frightened of a racing heart and who, while feeling happy and excited, gets a panic attack and is unable to understand the reason of it as he was happy. Let us see the cognitive perspectives. People with panic disorder have hypersensitivity for their bodily sensations, which are interpreted by them as a sign of an impending panic attack. The tendency to interpret bodily sensation as a sign of impending catastrophe, such as a heart attack, has been called catastrophizing. Such frightening thoughts start the vicious cycle as it increases the already present physical symptoms of anxiety, which in turn increase the catastrophic thoughts, which in turn trigger the panic attack. It should be noted that the person may be unaware about catastrophizing, as these thoughts are out of consciousness. And Beck has called these thoughts are as automatic thoughts, which actually trigger the panic attack. So if we see the Beck's model of explaining the panic attack, so he finds the reason for these automatic thoughts, which the person is not aware. So the cause of developing catastrophizing thoughts is not known. Nevertheless, only these people who have a tendency for catastrophizing develop panic attack. Individuals with panic disorder have a greater tendency to catastrophize their bodily sensation. If they have increased heartbeat or little bit pain in chest, so they may think they are going to have heart attack. So this cognitive theory of panic disorder also predicts that panic can be reduced or prevented by changing people's cognitions about their bodily sensation. So further likelihood of panic attack was significantly reduced when people suffering from panic disorders were given a detailed explanation of their physical symptoms. So if the medical model explained how these symptoms, how the like having pain doesn't relate to this or that, it should be explained clearly to the patient. So let us see the safety behavior. So panic disorders once developed is maintained despite contrary evidence, that is someone who has always suffered from a panic attack about having a heart attack on finding his heart racing, but never actually had a heart attack, should understand that a racing heart does not lead to a heart attack. But this logic doesn't prevent a panic attack, because each time the person was apprehending a heart attack, he indulged in a safety behavior like slow breathing. He take slow breathing and believed that this safety behavior prevented the heart attack. Or taking a glass of water, drinking a glass of water slowly and thinking that this will help in not occurring the heart attack. Thus, the safety behavior maintain the panic disorders. So we have to find out the safety behavior in the patient and then discuss about those safety behavior. Thus, people with panic disorder should be persuaded to abandon the safety behavior so that they could realize that their indulgence in safety behavior does not prevent the heart attack or any other impending fatality like fainting. Research suggests that dropping obsessive behavior by people with panic disorder increase the effectiveness of the treatment. But you are not just going to just say that you stop using. You have to first discuss and find out, and then explain those things. There is no connection between safety behavior or not having heart attack. After explaining everything, then patient may realize that yes, safety behaviors are basically not helping them. Coming to cognitive biases and the maintenance of panic. So people with panic disorder have a tendency for processing the threatening information in a biased manner, as we have already discussed. Such people interpret the ambiguous bodily sensation as well as other ambiguous situations as more threatening. Also, such people have a biased attention, also as they focus more on the threatening information, such as words indicating panic like palpitations, numbness, fainting, etc. fMRI studies have shown greater activation of memory areas that are involved in processing information. However, the role of biased information processing as a cause or as a symptom. Overall, it can be concluded that both biological and psychosocial factors have been found to play a role in the development of panic disorder, and neither of the two in isolation can explain its development. So the causes can be understood on the basis of both factors, biological and psychosocial factors. Coming to treatment of the panic disorder. So exposure therapy, as we have already discussed. So what we do in panic disorder, the exposure therapy for agoraphobia and panic involves exposing the client to the feared situation for a long period of time. The underlying idea is that the client, on being exposed to the feared situation for a long time without eliciting any harmful effects, help him to realize the futility of his agoraphobia with panic attack. So the client may get insight, okay, it won't happen. This exercise has been shown to be effective in treating 60 to 75% of people with agoraphobia and a maintenance rate of 2 to 4 years. A limitation of this therapy was that it did not deal with panic disorder specifically. Hence, another technique known as interceptive exposure was devised to deal with panic attacks in 1980s. This technique involves causing internal bodily sensations such as spinning head, nausea, breathlessness, which are associated with panic attacks, with the help of activities like sitting a client in spinning or rocking chair. When the client undergoes a prolonged exposure to such situation without getting a panic attack, the association of internal bodily cues to panic attacks get extinct. So the client get insight that okay, if I stay in this situation for a little longer period of time, there won't be any panic attack. So coming to CBT, so cognitively structuring integrated with exposure therapy used specifically to treat panic disorder is known as panic control treatment. It involves educating the client about the role of catastrophic automatic thoughts in causing and maintaining the panic disorder. During the therapy, the client is taught to identify the negative automatic thoughts and dispute or refute those in a logical manner using techniques like testing and humor. Then the client is exposed to the panic eliciting situations, both internal bodily sensation and external cues, to develop tolerance against the discomfort caused by such situations. This helped the client to deal with panic causing situations efficiently. It has proven to be effective in 70 to 90% of the client, and the maintenance rate of 1 to 2 years has also been reported. Medications. So medication is required in almost all psychiatric disorders if the severity is very high. So, medications like anxiolytics, which is also called anti-anxiety drugs, and antidepressant have also shown to be effective in treating agoraphobia and panic. Researchers, however, conclude that both drugs have advantages and disadvantages also. Anxiolytics, which belong to the category of benzodiazepines, include drugs like alprazolam or clonazepam, which have been shown to treat acute episodes of extreme anxiety as the drugs work quickly within 30 to 60 minutes. However, these have also side effects, hence must be taken as advised by the doctor. So the psychiatrists are the experts to advise this drug, and the patient and client should take drugs under the supervision of the doctor or as they have advised. They should not reduce or increase the dosage as per their wish. It should always be taken as per the advice or prescribed by the doctor. And one more thing, like if something helped one patient, it doesn't mean the other person can also take the same type of drug. So it should not be done like that. If one person is having panic disorder or phobia in the family and treated with the medication and now feeling better, and if the other person is also having anxiety disorder, so it is not advisable to take the same medicine without consulting the psychiatrist. Okay, thank you. So this was about the uh, phobia, social phobia, specific phobia, and panic disorders. So we have discussed about the causes, symptomatology, diagnostic criteria, and treatment of how to manage these disorders. So in our next class, we are going to discuss about the uh, same things, anxiety, mainly anxiety disorders, but specifically two things: generalized anxiety disorders and obsessive compulsive disorders. So in next class, I would expect from you go through the study material, read it, and then you will be better understanding about the this chapter. So generalized anxiety disorder is basically remains for longer period of time. It's like different as we have discussed in today's lecture, like anxiety and panic. Panic attack. Panic attacks are so intense, but it lasts for a brief period of time. Whereas anxiety is not so intense,